Dr. Sujata Darvi is joining. Madam is joining. You can start, Abhishek.
Sure. Okay, so very good afternoon to all the respected faculty members. On behalf of AMOGS Medical Disorder Committee and IOGS Indoor Obs and Gynec Society, I invite all of you for this COR Connect live webinar session. I am Bhumit Patel from Corona Remedies, and before moving ahead, we would like to start today's session with lamp lightning followed by Ganesh Vandana. So I request all of you to proceed ahead for lamp lightning.
Hello. Am I audible?
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
So on this session, let me take this opportunity to introduce Master of Ceremony for today's session, none other than Dr. Dhara Singh. Dhara ma'am, she is an assistant professor, Obs and Gynec in Mahatma Gandhi Memorial Medical College, Indore. She has done MBBS and MS from GRMC Gwalior. She is senior residency at MAMC New Delhi, AIMS Raebareli, and MGMMC Indore. She was in MS, also awarded gold medal in MS. She has published various papers in national and international journals. Also, she is faculty at AICOG 2022. So, without doing further delay, I would like to hand over today's session to Dr. Dhara Singh. Ma'am, please proceed.
Thank you, Mr. Bhumi Patel. Good evening, everyone. I am Dr. Dhara. A warm welcome to all the respected dignitaries who all have gathered here for today's event. I would like to invite Dr. Sneha Bhuyar ma'am, who is Chairperson Study on Female Breast Committee, Governing Council Member of ICOG 2021-22, recipient of National Award Foxy, Unsung Heroes, National Expert for UNICEF, National Adolescent Trainer, National Advisor BPN, Peer Review of Jogi. Over to you, ma'am.
Yes, Bhumik, you can stop sharing. A very good afternoon to everyone, and I'm very thankful to Indore Upsgani Society and of course my parent organization, AMOGS Association of Maharashtra Obstetrician Gynecological Societies, and I welcome respected Dr. Rajendra Singh Pardesi, who is the AMOGS president, and Madam Sujata Darvi, who is the secretary for AMOGS. With this, I just welcome all the esteemed faculties from Indore Obstetrics and Gynecological Society. I welcome Dr. Vidya Togri, who is the past chairperson of the committee. I welcome the panel moderators, Dr. Anupama Dave, Dr. Brajbala Tiwari, and all the panelists and chairperson. I would like to welcome the guest and guest of honor, Dr. Kavita Bapat and Dr. Archana Base for this program, which is planned exclusively on medical disorders of pregnancy. And I'm very happy to have Madam Sujata Dalvi, and I invite Madam for her words of wisdom and blessings. Madam is a very well-known personality in Maharashtra, and all of us fondly, we are very close in association with Madam, and she's very cooperative and very humble, generous personality, I would say. So over to you, Madam, for your blessings.
Okay. Thank you so much, Neha, for such kind introduction. At an outset, I would like to express my gratitude to AMOGS, especially President Dr. Rajendra Singh Pardesi and Sneha Buyar, AMOGS Medical Disorder Committee Chairperson, for inviting me to speak at this webinar. I would also like to express gratitude to Indore OBGYN Society for collaborating with AMOGS to have this webinar. And for that, I would like to acknowledge the efforts of Dr. Sneha Buyar and Dr. Jyoti Banglowala, two Jyotis, Dr. Jyoti Banglowala and Dr. Jyoti Karande from Indore OBGYN Society, and also Brijbala Tiwari from Indore OBGYN Society. You will always have a pearl and words of wisdom from our two past presidents from Indore, that is Kavita Bapat and Dr. Archana Base. And of course, you will have a good discussion on GDM management, infection, and hypertensive disorders of pregnancy. So I'm very sure that those who are attending today's webinar are going to learn a lot. And I would like to give my all the best wishes to all those who are willing to have some future role in Foxy for their endeavor in Foxy. So thank you so much for inviting me, and all the best wishes to all of you all for today's webinar.
Thank you so much, Madam, for your warm wishes and your blessings. Because Dr. Pardesi is operating and he will be joining later, we will have his blessings later. With this, I thank you, Madam, once again, and over to you, Dr. Dara, for further proceedings.
Thank you so much, ma'am. Now, I would like to introduce Dr. Brijbala Tiwari, ma'am, and Dr. Jyoti Banglowala, ma'am. Slide, please.
You can read, yeah.
Dr. Brijbala Tiwari, ma'am, is current Indore Obs and Gynae Society president, and she is past president of IOGS 2016 to 17. Next slide, please. Dr. Jyoti Banglowala, ma'am. Dr. Jyoti Banglowala, ma'am, is current vice president Indore Obs and Gynae Society, and she is past secretary of Indore Obs and Gynae Society 2021 and 22. Next slide, please. Dr. Jyoti Karande, ma'am, is secretary Indore Obs and Gynae Society 2022 and 23, member of Foxy Quiz Committee, joint secretary AICOG 2022, joint secretary BreastCon 2016. Next slide, please. Now, I would like to invite Dr. Jyoti Banglowala, ma'am, to introduce Dr. Kavita Bapat, ma'am, and Dr. Archana Base, ma'am. Ma'am is there?
Dhara ma'am is not there, so we will take this word of wisdom session when Dr. Archana Basir or Dr. Kavita Bapat madam will join. And at the outset, I want to thank Dr. Sneha Buyar madam for always taking lead in all the academic activity. And this time, as a AMOGS Medical Disorder Committee chairperson, she collaborated with the Indore Gynec Society.
Thank you so much, my dear.
We all are very thankful to Sneha Buyar madam, and my earnest appeal to all our members to vote for her. And whenever Dr. Kavita Bapat or Dr. Archana Basir madam will join, we will take this session, and we straight away will be going to academic session now. So Dara, you can take over the mic.
So now let's start the scientific session. The first session is on GDM management. I would like to introduce our chairperson, Dr. Jayashree Sridhar ma'am, and Dr. Sumitra Yadav ma'am. Slide, please. Dr. Jayashree Sridhar ma'am is from KMC Chennai, MGM Indore. She is core fertility specialist in Morpheus Hospital Indore, vice president Indore Society, and she has 26 years of practice in obs and gynae and laparoscopy. Next slide, please. Dr. Sumitra Yadav ma'am.
Dr. Sumitra Yadav.
Dr. Sumitra Yadav, ma'am, is Organizing Secretary, IH National Conference, Star Endogynec 2019. She has teaching experience of 29 years, and she is MP State Nodal Officer for Laksh. She is awardee of Nari Shakti Award, Brajbhumi Foundation of Hema Malini, Nai Dunya Naika Award on Distinct Social Services in 2012, Young Scientist Award 2000, State Award of Karnataka CBSE National Topper of 10th and 12th, Best Paper Presentation Award in BreastCon 2018, and Best Paper Awardee on Endoscopy in Endogyne at Agra 1998. Next slide, please.
Bhumik,
No,
we
back
need to
one.
be fast. Next slide, please.
No, ma'am is not there. Please, back slide, please. Now, I would like to invite Dr. Jayashree Sridhar, ma'am, to introduce Dr. Sneha Bhuyar, ma'am.
I think my introduction has been already done. Bhumik, you can stop sharing.
Can we ask Dr. Jayashree to introduce for the topic also?
Dr. Sneha Bhuyar, good afternoon. Good afternoon, Dr. Braj.
Good
Dr.
afternoon.
Jyoti and Dr. Jyoti Banglowala, Dr. Karande, Dr. Anupama Dave, all of you, hi. Dr. Sneha is going to tell us about the newer trends in the management of gestational diabetes, which sure is another parallel pandemic going on in India. So over to you, Dr. Sneha.
Thank you so much, Dr. Jayashree. Truly said, yes, it is another pandemic, as we are, defamed for this, that we are the capital for diabetes. India is a capital for diabetes, and the rising trends of GTM, as you can make out from the incidents, what has been, we are watching over last few years almost. So today I'm supposed to speak on the management of gestational diabetes mellitus. But the management should start from prevention. And that's the very reason how we can prevent it. I would start with that. So gestational diabetes mellitus, actually it is the glucose intolerance or hyperglycemia of variable degrees, which is recognized during pregnancy for the first time. The patient may or may not have hyperglycemia before the pregnancy, but it is diagnosed for the first time during pregnancy. And the rising incidence you can see here. In US it is 14% and India it is 20 to 27%. We are even more than Sri Lanka, Bangladesh. They are reaching only up to 9%. So why there is gestational diabetes, that is diabetes during pregnancy? Why pregnancy is a diabetogenic condition? As all of you know that placenta produces hormones like estrogen, progesterone, human placental lactogen. And these are the same hormones which they inhibit or antagonize the action of insulin. And that's a very reason the mother's blood glucose levels are increased to a great extent. And this hyperglycemia, this blood with high sugar levels, when it reaches the fetus, the fetal pancreas is stimulated to a large extent. The beta cells start secreting more and more of insulin. This utilizes the extra sugar, and of course, extra sugar is deposited as fat, and that's a very reason you get the macrosomic baby in hyperglycemia. Insulin resistance is the main culprit for this. All these conditions, including type 2 diabetes, hypertension, impaired glucose tolerance, obesity, polycystic ovarian syndrome, endothelial dysfunction, acanthosis nigricans, and so many other dyslipidemias, accelerated atherosclerosis. Now, why are we worried so much about this condition? Why we are talking about the blood sugar levels during pregnancy? Because it is directly correlating with the perinatal mortality. So if you have the blood sugar levels of more than 200, the perinatal mortality is almost 35%. If you have 150 to 200, it is 16%. 100 to 150, it is 8%. And if it is around 100, then the perinatal mortality is only 4%. So these figures, they bring, they actually tell you that what is the impact of high blood sugar on the perinatal outcome. And that's a very reason screening, early diagnosis, and prompt treatment is very, very essential. So these women should be told about what should be the target levels of sugar before breakfast, lunch and dinner, and post meal, how it should be. So why are we worried so much? As we have already discussed, that it increases the perinatal mortality. But that's not the only thing it leads to. It puts the mother also at risk of preeclampsia, vasculopathy, retinopathy, nephropathy. It also leads to macrosomia of the baby, and that associated labor dysfunctions, traumatic delivery, operative interventions, of course, the spontaneous abortions and preterm labor, which the mother has to suffer for. GTM puts the baby at risk. It leads to neonatal hypoglycemia, hypocalcemia, even prolonged jaundice, hypothermia, and polycythemia. The neonatal respiratory distress syndrome that happens because of the hyaline membrane disease or the surfactant deficiency. Because the baby is large, the prolonged labor, shoulder dystocia, birth trauma, and of course the long-term complications like obesity, type 2 diabetes, and even the metabolic syndrome can happen because of this. And that's the very reason mother and baby both are affected. So we should screen for this condition. We should screen all the women, or whether we should screen only the high-risk women. So previously we had this concept that women with polycystic ovaries, obese women, those with family history of diabetes, and also those above 35 years previously, only they were screened. But because of this, almost 30% of the women who later developed GDM, they were missed. And that's a very reason Foxy, Figo, NHM, DIPSY, and all of them, they came up with this idea of universal screening for gestational diabetes mellitus that is mandatory for all pregnant women during every pregnancy. So when and how do we do this screening? The screening is universal. It has to be done at 2 times. First, at the very first point of contact, that is first antenatal visit, whenever it maybe in the early pregnancy, maybe in the late pregnancy, but the moment the woman comes to you, you should screen her for GDM. And then the second visit or the second screen should be between 24 to 28 weeks. These are various organizations which are giving you different values for the blood glucose levels, which we will not discuss about. We have to only remember what is the standard national guideline for diagnosis and management of gestational diabetes, which is unanimously accepted by the Maternal Health Division of Ministry of Health and Family Welfare, Government of India, NHM, Foxy, Figo, DIPSY. So what is called as single step 75 gram OGCT, that is oral glucose challenge test. You give a challenge of 75 gram of glucose to a woman who may be full stomach, whatever may be the time for her last meal. So she need not be nil by mouth, but she can consume 75 gram of glucose, and then she can be tested for what is her reaction, what is the blood levels after 2 hours. So how this test is done? Whenever she visits your clinic, she is given 75 gram of glucose, which is to be dissolved in 300 ml of water. She has to consume this over 5 to 10 minutes. The time is noted down. After 2 hours, the plasma glucose levels are done. If this glucose levels are more than 140, then she is labeled as having GDM and managed accordingly. If these levels are normal, she is labeled as normal, but this test has to be repeated at between 24 to 28 weeks. And even that time, if her levels are more than 140, then she is labeled as GDM and managed accordingly. Suppose some women come to you late during second or third trimester, but still you have to do her OGCT If she comes only after 28 weeks, she requires only single testing. And if she comes later during second trimester, we have to make sure that her gap between the two testing should be at least 4 weeks. So that is how the methodology we have discussed. And once you label her as GDM, then how do you manage these women? So as I have already said, that management should start from prevention of GDM. So how do we guide these women? We have to guide them about their diet, exercise. Suppose a woman comes to you for pre-conception counseling, then we have to guide her on her diet, exercise, optimizing her weight and BMI. If at all possible, we can give her some probiotics and maybe some insulin sensitizer. But once she comes to you as diagnosed GDM, then how do you go ahead? Once you label her as GDM, then you have to give her 2 weeks time. You advise her medical nutrition therapy. That means whatever you have to calculate her calorie requirement. You have to recommend her spread, how much carbohydrates, proteins, fat, how much it should be. And then simultaneously, you have to advise her active physical exercises. With this, you have to repeat the plasma glucose levels, that is 2 hours postprandial glucose levels after 2 weeks. Now, if this 2 hours postprandial glucose levels, if they are less than 120 milligram percent, well and good. That means she is well managed with the medical nutrition therapy itself. So here you have to ask her to continue the same medical nutrition therapy and test for the blood glucose levels every fortnightly up to 28 weeks. After 28 weeks, you can, if she is stable enough, you have to repeat it every weekly. But suppose this lady, after 2 weeks, when you do her blood sugar levels, if the blood sugar level is more than 120 milligram percent, that means she has not responded or not getting control with MNT alone, then you have to put her on some drugs, and the drugs can be either metformin or insulin. Majority of the organizations have come to the conclusion that insulin is the first line of management, and that is why we should prefer insulin. And once you put the patient on insulin, then you have to monitor the blood sugar levels very frequently. So we have talked about the general management as well as medical therapy. Medical therapy, you have two options, that is oral hypoglycemic agents and insulin. But whenever you are giving insulin, you need to monitor the patients frequently. For a metropolis cities or a larger towns where you have all the facilities and infrastructure available, you may put the patient on insulin and manage accordingly. But for remote places where you don't even have the consultant obstetrician or even the GDM trained staff as well, so there it is very difficult. So the management of diabetes mellitus, it actually something is better than nothing. So you have to just see the management should be in accordance with the available national resources and the infrastructure. So you may just start her on some medication, you control her sugar levels, and her frequent follow-up, whatever local staff can be done. In fact, you have to train her for self-monitoring of blood glucose levels. FICO also recognizes the importance of nutrition, counseling, and physical activity, what we have labeled it as MNT. But the nutrition counseling should not be in a scientific way and the medical jargons. It has to be very, very practical, because that gives you maximal prediction and maximum control. If the woman can control her diet and she can test her sugar herself, that can give you very stable sugar levels for herself, which is done with the self monitoring. So why diet is so important? Because that gives you that helps you in managing the blood sugar levels. At the same time, it allows you optimum weight gain, and it gives you all the necessary nutrients which are required for the mother as well as fetus. So how is the efficacy of medical nutrition therapy? Nutrition interventions has been recognized as the cornerstone of the therapy. Almost 30 to 90% of the women, they are well maintained on MNT. Only few patients, they require the medication. And one more thing which I have said, the recommendation of the caloric intake, how it should be. So it is not same for all women. It is according to the BMI. If a woman has normal weight, that is the BMI of 18.4 to 25, then you have to give 11.5 to 16, and then for an underweight lady, it should be 12.5 to 18. So accordingly, your intake should be decided, and it shouldn't be a stereotype. It should be a tailor-made requirement. Carbohydrate has to be cut down. Usually 55 to 60% of the total calories should be for carbohydrate for a normal pregnant woman. But for a diabetic, that means a GDM woman, we have to restrict the carbohydrate intake to maybe 40 to 50%. Now we have to tell them what is the importance of the food they are consuming. They should go for the low GI foods. So what is this low GI? The glycemic index is actually a figure representing the relative ability of the carbohydrate food to increase the level of glucose in the blood. So low GI food products like legumes, lentils, dried beans, and all those Bengal gram, these are rich in fibers. They have low GI, less than 55%. Medium GI, they are the fruit. Fruits are having medium GI, and high GI, they are cereals like rice, white bread, root vegetables like potato and carrot, all these things. So we have to teach her to consume the low GI foods, to prefer the low GI food. So if at all she is having her regular diet this way, this is just an example how you can teach her that if she's taking sugar, you just tell her that it will be better if she takes honey or jaggery in place of sugar. If at all she's taking roti, then she has to take brown bread or so. So that is how you have to see how you can replace her food, or you can give her food substitute. Regarding fat, it is total fat fat, that is 20 to 35% of the total calories should be fat, and it should be specifically this is a chart which is showing the polyunsaturated fatty acids, the monounsaturated fatty acids, and how you have to prefer which one. So all these are the foodstuffs. I'm not going to read it, but the most preferred one is a polyunsaturated fatty acids, that is soybean oil, rapeseed oil, mustard oil, walnut oil, and fatty fish. All these things, these are the fats which are a little healthy as compared to the rest of the fats, and we should avoid. So according to the color code, the green ones are the most preferred, poly and mono. The N6 fats, the saturated fatty acids and trans fatty acids are colored as red because they should be avoided as far as possible. Protein requirement, almost 25 to 30% of the total caloric requirement should be fulfilled by proteins. So if you explain her how should be the spread of her thali, half the thali should be having a non-starchy vegetables, and remaining half the fistful of the proteins and only few fats. That's how the spread should be. These are the various examples, the food items named here: meat and lean meat, the lean meat, fish, cheese, eggs, beans, hummus, and nuts and seeds. These are the proteins actually which should be very helpful. So now, once we have said that 30 to 90% of the women, they are well controlled on medical nutrition therapy, but only almost 10% are the women who are not well controlled on MNT, and these are the ones who require medication. So now we talk about the pharmacological agents. Just I have quoted earlier that metformin or insulin therapy, these are the accepted medical management of for pregnant women with GDM, not controlled on MNT. But insulin is the first drug of choice, and metformin can be considered after 20 weeks of gestation for medical management. This is according to the Ministry of Health and Family Welfare, Government of India. Now coming to the suppose women who are not responding to MNT, and you put her on insulin. So how do you decide that? So you have a woman who is diagnosed recently as GDM. You give her 2 weeks time. Her after 2 weeks with MNT, her blood sugar level 2 hours postprandial blood sugar level has come less than 120. So that she is well controlled on MNT. So you have to continue with the same MNT and physical exercise. If her blood sugar level comes as more than 120, then you have to put her on insulin. How much insulin you have to start and which insulin? You have to start with human insulin, that is a premix of 30:70, and it is given subcutaneously. All of you know this. How much? If the blood sugar levels are between 120 to 160, then you start with 4 units. 160 to 200, you start with 6 units. More than 200, you start with 8 units. And how frequently do you monitor? If you're really worried about the fluctuations, maybe for first 1 or 2 days, you may do 4-point or 6-point testing. And that's the reason you have to hospitalize. But if it is quite stable, or you have stabilized her, then maybe every 3rd day you can go for the fasting and postprandial 2 hours blood sugar levels. Suppose the blood sugar levels with this insulin, it remains, fasting remains less than 95 and postprandial remains less than 120, then you have to continue with the same dose of insulin along with MNT and physical exercise, and then you repeat it every fortnightly. Repeat the blood every 3rd day. If it is stable, you repeat it every fortnightly. If it is not stable, you repeat it every 3rd day, and you see whether the fasting or postprandial sugars are high. If the fasting sugar is more than 95, then you have to add 4 units to the 4 units of insulin the day prior. That means before dinner. If the postprandial sugar is coming more than 120, then you have to add 2 units just before the breakfast. So that is how you have to add the insulin, and then again you do the blood sugar levels till you achieve the target levels of fasting 95 and postprandial 120. So you continue the same dosage, and simultaneously you continue the monitoring of the maternal as well as fetal well-being. Monitoring every 3rd day, the postprandial sugar 2 hours postprandial. So you continue to monitor every 3rd day till you achieve salvageability or you reach the term. So how do you decide this? When you are monitoring the mother and fetus, maternal condition, if it is absolutely fine and she is showing good control, simultaneously you're monitoring the fetus. So if everything is fine, you need not do any hurry. You need not plan for her delivery. Wait for spontaneous labor. If you have the weight, baby's weight of less than 3.8 kg. If baby's weight is 3.8 plus, large for gestational age, then you have to induce the labor between 38 to 39 weeks. And if the baby's weight is more than 4 kg, then definitely you have to offer her elective cesarean section. What do you do when the patient starts or goes into labor? The patient needs to be well hydrated. The hydration needs to be maintained well. The blood sugar has to be tested every hourly. We have to see that it remains in the range of 100, 105, and it does not go low so that she doesn't develop hypoglycemia. You have to keep infusing her as per the sugar levels, whether she needs NS, whether the sugars are going low, then maybe you have to start with DNS and insulin infusion. If at all you have planned elective cesarean section, you have to skip the dose of insulin that day, and then after the delivery or after the cesarean section, you have to titrate the sugar levels with the infusions. So if at all needed, then only you have to add the insulin to the infusion. After delivery, all of you have experienced it, that the sugar levels go substantially down and you may not even need the insulin therapy. But if at all the blood glucose you want to monitor, if it is 90 to 120, then you don't need any insulin. If it is 120 to 140, then you just add 4 units in the infusion. If it is 140 to 80, add 6 units. And if it is more than 80, then you add 8 units in the post-operative infusions. naturally postnatal visit, you will keep on monitoring the blood sugar levels. You will do it for first 2-3 days daily. And then later on, you will just advise her to maintain the medical nutrition therapy. That is the proper diet and exercise, the weight reduction, and of course continuation of breastfeeding, which actually helps you reduction in the breast weight, as well as the calories are burnt, 500 calories per day. And then she has to do the glucose challenge test after 1 month and 6 weeks, and that's how she has to take care of her glucose levels. The preferred method of contraception is copper T, as you can see here in this chart, because she is not a good candidate for hormonal contraception. So I think that is all about the GDM. So the take home message is GDM has profound adverse effect both on the mother as well as fetus. So it should be prevented rather treated. And every pregnant woman in the community should be screened irrespective of her risk status for at the very first antenatal visit, and then between 24 to 28 weeks. 2 weeks time should be given for MNT, and diet and exercise play a major role. Of course, the treatment should be with diet and exercise as far as possible, but drugs when needed. Insulin is the first drug of choice. Metformin can be added after 20 weeks, if at all there are no facilities available for testing and monitoring. So friends, thank you so much for the patient listening. And with this, I seek all your blessings and your best wishes for my candidature as Foxy Vice President from West Zone for the upcoming elections. As you all know, West Zone being a large zone, we have 2 posts here, and I request you for your one valuable vote to be casted in my favor. Thank you so much once again, all of you.
Thank you.
Thank you so much.
Thank you.
I can see Dr. Kavita Bapat. Welcome.
She's
madam.
joining.
Yeah. Hello. Good afternoon. Please unmute. Please unmute yourself. Good afternoon. And myself, Dr. Sneha Buyar, as AMOGS Medical Disorders Committee Chairperson, welcome you wholeheartedly.
Hi, I welcome Sneha to our Indore.
Yes,
सब
thank you so much.
लोग अपना अपना वीडियो ऑन करो, मेरे को दिख नहीं रहे हैं. Yes, thank you. Hi. बस that's the only program we have. Hi नीना. इंदौर में मैं रहती नहीं हूँ और तुम लोग मुझे दिखते नहीं हो. So I am so happy. अनु, धारा, ज्योति, रेखा, ज्योति, सुमित्रा डार्लिंग, हंसाली, and देवेंद्र कौन हो तुम?
Corona remedies.
Oh, okay.
नहीं, देवेंद्र is from Bombay Hospital.
Bombay Hospital.
मैंने सोचा इसको क्या हो रहा है, देवेंद्र को मैं जानती हूँ. चलो, good. And जयश्री सो रही है शायद. So thank you so much, Neena Devi. So बस welcome Sneha. Thank you so much.
Thank you.
And welcome to Indore. And all the best to you. Thank you so much.
Thank you so much.
Thank you so much. Braj में जाऊँ.
Thank you, Didi, for joining me.
बालों में कलर कराना है.
2 मिनट रुकिए मैडम, हमको भी एक वोट अपील करनी है.
We want to have your words.
हमारे 13 लोगों में तू कौन सी वोट अपील कर रही है?
मैडम, ये 13 लोग तो फैकल्टी, बाकी सब लोगों के लिए वोट अपील करनी है कि हमको.
बाकी कौन सुन रहा है इसको?
अरे बहुत सारे सुन रहे हैं.
अच्छा, sorry, I never knew. चलो, okay.
सारे के सारे
ज्योति बंदे मैडम, thank you.
हम चाहते हैं कि हमारे जो डायनामिक वाइस प्रेसिडेंट है वो वही वाले हमको एज ए प्रेसिडेंट मिले, तो वो वोट अपील हमको करनी है. काइंडली वोट फॉर डॉक्टर कविता बापट. It is the earnest appeal from the Indore Society to all the AMOGS societies joined.
Okay. Thank you so much. I thought. Chalo, continue. So, but such a nice faculty you have and nice topics. Thank you so much.
Thank you,
Didi, for joining.
Thank you so much, ma'am.
Thank you for joining.
Love you all. Bye.
Dr. Sumitra Yadav, ma'am, has also recently joined. I would like to introduce her. Please share her slide, please.
Yeah, if at all, we have the chairpersons, we can have their comments and if at all discussion.
Yeah, Dr. Sumitra ma'am is here.
The next one. Next slide. Next one.
Dara, you can invite directly.
Okay.
और ऊपर होगी, और ऊपर.
I would like to invite Dr. Sumitra Yadav ma'am to conclude the talk. Dr. Yadav ma'am is awardee of Nari Shakti Award, Nai Dunya Naika Award, Young Scientist Award, State Award for Karnataka, Best Paper Presentation Award in BreastCon 2018. Over to you, ma'am, for DDM talk.
Yeah, it was. I must first thank all the organizers for giving me space here. What I would like to compliment is that you have selected very good topics that are of everyday importance to the gynecologist. And I should also compliment Dr. Sneha Bhuyer for this wonderful, comprehensive, practical talk and the practical tips that she was giving regarding the insulin level according to the sliding scale. I was noticing that she touched upon the nutrition point. I'm confident that the people who are listening to this will be benefited by this particular talk of how to manage diabetes and how to, very practical tips. If the baby's weight is how much, how to wait or to go for cesarean section. I'm confident that everybody has enjoyed this talk. And yes, we shall vote for Dr. Kavita Bapat. This is a good platform. Dr. Brajbala Tiwari, Dr. Jyoti Banglowala, and we'll add on Dr. Sneha Bhuyer to this. Thank you very much.
Thank you so much, madam. Thank you for your blessings and your words. Thank you so much. I appreciate it.
Thank you so much, ma'am. Moving to our next session.
बसीर मैम ने ज्वाइन किया?
मैम
देख नहीं रहे ना?
नहीं मैम.
ठीक है.
Should we move to our next session?
So,
panel
Dr.
discussion.
Vidya Thobi madam will join late. We have
Okay.
to start with
You
panel.
can start with the panel.
मैडम आप ज्वाइन किया हो क्या? हेलो मैडम जस्ट धारा.
Yes, ma'am.
हेलो धारा, बसीर मैडम है ज्वाइन.
Okay.
आपका हो गया है? I was here only. Okay मैडम. नहीं मैडम, इसमें इंदौर वाले वेबिनार में, IOGS एमॉग वाले में,
कोर कनेक्ट वाले में मैडम,
कोर कनेक्ट वाले में. मैं आपको पर्सनल भेजूं फिर से? हाँ.
Yes, you
मैडम
send
उसी
her
के
the
लिए
link
किया.
so that she can join.
मैडम आई एम सेंडिंग फॉर दिस लिंक. ज्योति ने इसी के लिए कॉल किया होगा आपको. ठीक है. विल यू ज्वाइन?
मैडम ने वो प्रैक्टिकल ऑब्स्टेटिक ज्वाइन कर लिया था.
मैं कर लेती हूँ. आई एम सेंडिंग द लिंक, यू कैरी ऑन. आई एम सेंडिंग द लिंक.
So meanwhile, मैडम बस saying कि ज्योति ने कॉल किया था. ज्योति, but madam had joined that practical ops, I think. So she will join.
मैंने ज्वाइन किया था तब मैडम ने प्रैक्टिकल ऑब्स्टेटिक कर लिया. मैंने उधर देखा उनको अभी.
चलो.
Now she will join.
So you did you send her the link?
Yes,
Again we sent her link.
Send. She has seen the link. She's joining.
So we can wait for 1 minute.
Madam, Dr. Archana Basir, welcome. Good afternoon.
Hi Sneha, how are you?
Hi, hello, my dear. Welcome.
Good to see you.
Yes, thank you so much. Thank you so much, Team Indore, and thank you, Dr. Archana, for joining. We would like to listen to your words of wisdom and have your best wishes. Please unmute yourself.
Hi. Wish you all a happy Republic Day, which is coming tomorrow.
Yes.
And all the best for the webinar. I think this is very, very important to connect with all via the webinars. I know that now we are again back to the conferences, and meeting in person is really more, good. And we feel much elated after meeting the friends. But webinar is still a way of connecting with each other. And I wish all the best. And to IOGS, to your committee, Sneha, and for your future endeavors as well. And thank you for having me here.
Thank you so much, Dr. Archana, for your best wishes, and thank you. We're very privileged to have you here. Thank you so much.
मैडम आप लोगों के बिना सुना सुना लग रहा था, कविता दीदी और बसर मैम ने ज्वाइन नहीं किया था तो so thank you very much ma'am for joining.
Thanks, Brij, for kind invitation. It's always good
Madam
to see
joined
all
in the
IOGS.
another webinar.
I think you know what happened, because there were 2 webinars and I logged in there, and then Maitra Saxena got hold of me as guest of honor.
Madam, that was the iliac artery ligation. That was the
Means,
ligation.
yeah, iliac artery ligation, and so many phone calls were coming, so I logged it.
I called you for this medical disorder committee IOGS.
It's okay, no, I can be at 2 places.
That's the advantage of being virtual.
I know.
Multiple programs and enjoy all the company as well. Thank you so much.
Thank you. Thank you, madam. Thank you, Basir madam.
I think we can
Thank you so
start.
much, ma'am.
Yeah.
Moving to our next session, that is panel discussion on hypertensive disorders in pregnancy. We have galaxy of stalwarts here for this discussion. I would like to introduce our moderators. Slide, please. Dr. Professor Anupama Dave, ma'am. She is professor at MG and unit head at MG Medical College, Indore. She is presently working as superintendent MTH Hospital, recipient of Dr. C.S. Dawn Best Paper Award, AICOG 2012, Varanasi, Master Trainer and Nodal Officer of FOXI, EBOC training, and Master Training of IPAS CAC training. She has publication in 45 national and international journals. Next slide, please. We have next moderator, Dr. Brijwala Tiwari, ma'am, who is current president IOGS and past secretary IOGS. Next slide, please. Now, I would like to introduce panelists, Dr. Sadhna Mehta, ma'am. Next slide, please. She is obstetrician and gynecologist with 29 years of experience in dealing with high-risk pregnancy, infertility, and laparoscopy. She has received award for Limca book record for operating huge para-ovarian cyst of 10 into 12 inches in size. Next slide, please. Next slide, please. Our next panelist is Dr. Poonam Mathur, ma'am. She is professor, Department OBGY, MGA Medical College. She is president, MP Teachers Association, Indore, and past president, Indian Menopause Society, 2018 to 2020. She is master trainer for FOXI EMOC training and master trainer for IPS CAC training. Next slide, please. Our next panelist is Dr. Neena Agrawal, ma'am. Next slide, please. Our next panelist is Dr. Rekha Agrawal, ma'am. She is currently working as associate professor at Index Medical College. She has done MBBS from Calicut Medical College and MS from GSVM Medical College, Kanpur. She has teaching experience of 12 years in medical college. Next slide, please.
Panel शुरू हो रहा है. ठीक है.
Our next panelist is Dr. Hansalini Bharti, ma'am. She is consultant gynecologist in Indore, ex-resident of Royal Women's Hospital, Melbourne. She is awardee of Best Research Paper in Tuberculosis, IFS, Best Poster at MP OBGY Conference 2017, and Dr. Kumud Tamaskar Award as a co-author at AICOG 2009. Next slide, please. Our next panelist is Dr. Devendra Patil, sir. He is obstetrician and gynecologist, infertility specialist, and advanced laparoscopic gynec surgeon. He has done MBBS from Turner Medical College, Navi Mumbai, batch 2004, and pursued MS in obstetrics and gynecology from KEM Mumbai. He worked as a freelancer laparoscopic surgeon in Mumbai for 3 years. Next slide, please. No, back one. So over to you, ma'am, for panel discussion.
Anu, you will share slides?
Yes, I'll share the slides. A very good evening to all of you. Just a minute. Very good evening to all of you. At the outset, I would like to thank the organizers, Dr. Sneha especially, for inviting me to this panel. And to begin with, I would like to invite my co-moderator, none other than the gorgeous IOGS President, Dr. Brajbala Tiwari. And then I invite on board all my panelists or experts who are from Indore Society and they are stalwarts. Dr. Sadhna Mehta, Dr. Poonam Mathur, Dr. Neena Agrawal, Dr. Rekha Agrawal, Hansali Nima, and Dr. Devendra Patil. Now, to begin with, preeclampsia is a complex medical disorder worldwide and is responsible for a lot of deaths, more than 500,000 fetal and neonatal deaths and more than 70,000 maternal deaths.
Anu, slide share is not there.
You cannot see. You cannot
Yes.
see slides.
No,
Ma'am, you can once stop sharing this slide and once again you share the slides.
On my screen, it is there.
No, it's not visible.
Okay. Now is it okay?
No, it's
Yes,
okay.
now is it visible, ma'am? Yes.
So as I was telling, preeclampsia can deteriorate rapidly and without warning. And this is the reason why we need to create an awareness among physicians as well. It is not only a cause for mortality, but a cause for morbidity as well. Simple pregnancy-associated hypertension could also have bad consequences. And recent evidence has confirmed that pregnancy-associated hypertension can cause late problems like early childhood cardiometabolic disorders as well. So let us now move on to the panel. My first case scenario, Mrs. W, age 26 years, is a homemaker. She's married for 6 months. She came to the hospital having missed her period since 2 months. Findings on examination were her BP was 143 by 92, pulse rate 100, BMI 25.4, urine NAD, and mean arterial pressure of 106. So my first question, rather set of questions, is for Dr. Sadhna Mehta. When should we check her BP again for confirmation? So is Dr. Sadhna here?
I was calling her. She was not picking phone, and I think.
I can see.
Okay, I'll call her again. You continue with the panel. I will call her.
Anyone else?
Hello.
Will
Am I
you
audible?
Yes.
Yes.
Because this is her first visit and her blood pressure is on the higher side, I would like to repeat her blood pressure after 4 hours. Maybe that she's scared visiting the doctor for the first time, as we say, as a white coat hypertension. So repeating a blood pressure again, lying down, sitting position after making her comfortable. And still if her blood pressure is this, then we really need to do other investigations and check her.
Now, history taking is quite important in such cases. What other things would you like to elicit?
The most important is if there is any family history of a hypertension, or if she herself is a hypertensive and she has not told us in her history, or a renal disease.
Yes. Then mean arterial pressure is 109. How do you calculate this mean arterial pressure?
We calculate it by diastolic pressure plus 1/3 of the pulse pressure.
And there's a new term, testosterone score. So could you tell me her Gestosis
See,
score?
Gestosis score is a very nice scoring system. Every one of us can have it on our table and we can give a score to our patients. The scores go by 1, 2, and 3, and different factors are there. Like if she's an elderly primey or a teenage primey, if she's been married for say less than 6 months, family history of hypertension. There are many scorings given. And with that, we can score our patient if she falls in the high risk group or not.
Yes. So for this patient, the score was of 3. As you can see, universal screening is recommended and there is no single effective screening method. And for this, the HDP Gestosis score has been proposed is an effective and feasible prediction policy. Now, scores of 1, 2, and 3 are allotted to different high-risk factors. When the total score is equal to or more than 3, pregnant women should be marked at risk for preeclampsia. These are the risk factors, 14 risk factors which have been labeled or which have been given a score of 1. And for our patient, she's a primary gravida, short duration of sperm exposure, that is cohabitation only 6 months, and mean arterial pressure more than 85. That's why she gets a score of 3. These are the other risk factors, 6 of them, which have a score of 2, and further 7, which have a score of 3. So this is how we calculate the Gestosis score. Now, next question. I think Neena ma'am, you can continue. What investigations or just a moment. Next set of questions is for Dr. Poonam Mathur. Poonam Didi, are you there?
Yeah, I'm here.
So what investigations would you like for, or would you ask for this patient?
Basically, when we talk about the investigations, the routine CBC we need to do, then the LFTs in which we see the serum bilirubin, apart from the routine test I'm talking about. So regarding this BP related problem, so we need to do the LFTs in which we see the serum bilirubin, we see the AST-ALT, and also the AHD, sorry, and serum creatinine and blood urea. That also is to be given, and the protein, the urine protein creatinine ratio.
Yes. So all routine ANC profile plus some special investigation, as Didi has rightly said, for target organ damage. Now, she says that she has a home monitoring BP apparatus and is willing to check her blood pressure every 4 hours and will come back with recordings. When she comes back the next day with her reports, all are within normal limits, like they were less than 140/90. You check her BP again, it is 145/94. So what is the diagnosis now?
This is a classical example of white coat hypertension, in which patient is comfortable in other settings or maybe at home. And when she comes and visits the medical personnel or the medical care provider, then her BP shoots up. So in such a case, this is called as a typical white coat hypertension. And in this case, we have to be watchful. Maybe that she will develop hypertension later on. But right now, nothing is to be done. We just keep monitoring this patient.
Yes, this condition is seen in 13% of women. It is not associated with tachycardia and they are not necessarily old and they do not respond to pressure substances. Morbidity is higher than in normotensive, and this is the reason why they need to be monitored. Now, next question, is nighttime BP different from daytime BP?
Yes, nighttime BP is generally lower than the daytime BP.
Yes, and if it is raised, it is a stronger predictor of adverse outcomes.
Yeah.
So now coming to the next question is for Dr. Neena. Does this patient have a higher risk of preeclampsia?
Actually, this patient will need a close supervision and monitoring of the blood pressure. She can develop preeclampsia, and if her BP doesn't settle every time she comes to the clinic, I think even a low dose of beta blocker will be able to control her BP.
So what is important is that we need to get an ambulatory blood pressure measurement. So at home or ambulatory monitoring system should be there, so that we know that only at hospital her blood pressure is raised. At home, it is normal. So these cases, if it is raised in the hospital, then only an antihypertensive is required. The risk in these women are for developing, relative risk for developing preeclampsia is 5.4, and for developing FGR is 2.4. Worse perinatal and maternal outcomes is there than normotensive, but better outcomes than gestational hypertension and chronic hypertension. As you can see the triad, initially there's white coat hypertension, which may then progress to gestational, and in a few cases, the worser spectrum is of chronic hypertension. These women require monitoring for preeclampsia and for SGA and for preterm birth. The next question is to you only, ma'am. Should you monitor her?
Anupama, Dr. Sadhana Mehta had joined. So.
Oh, it's okay now. So, Dr. Neena, should you monitor her throughout life?
Actually, yes, she should be.
Yes. Because they are...
She is at a higher risk of developing hypertension.
Yes. Now, place of antihypertensives in white coat hypertension.
So actually, they don't need any active treatment unless lot of anxiety and stress. So then they can be given a mild dose of beta blocker, very low doses.
Yes, because those who have cardiovascular risk factors, they definitely require antihypertensive therapy. But if they do not have any such risk factors, they can be monitored and they can be advised lifestyle changes. My next questions are for Dr. Rekha Agrawal. What about aspirin as a prophylaxis against preeclampsia?
Thank you, IOGS Indore. It's a wonderful foxy part of the Indore that they always conduct such a wonderful sessions, and all members, senior members are very, very helpful and very cooperative. All the Dhurandars of the foxy are in Indore, we can say. Thank you, ma'am. So this question is about the aspirin. So aspirin is definitely having a role in prevention of the preeclampsia as well as for the better outcome of the fetus, because it in the low doses when it is given, so low doses we say 75 to 150 milligram per day, and it especially inhibits the COX-1 inhibitor, and it reduces the production of thromboxane A2, thus it reduces the vasoconstriction. And moreover, it reduces the inflammation in the vessels and platelet aggregation, and thus it increases the blood flow. It increases the placental blood flow, and the baby's growth is also improved. So aspirin has a very good role in preeclampsia, and we usually give 150 milligram at night. Because it has to be proven that when we give aspirin at night, then it reduces the systolic as well as diastolic blood pressure rather than giving in the daytime.
So this was a good option, that giving it at night is better, because we've seen that blood pressure rises more. If it is more at night, then it is significant. Now, this woman who had white coat hypertension, surely we would start low dose aspirin. How does white coat hypertension compare with gestational hypertension?
White coat hypertension needs the monitoring and not the proper treatment should be started unless we get the ambulatory readings to be high. And we advise the patient that the home reading should be, if it is more than 135 and 85, we have kept the cutoff less than 140/90, because that we presume that in the hospital we take it 140/90, but at home it should be 135/85. If it is more than that, then we take it consider, and then only we should start the treatment.
Now, it is that cardiovascular events were similar for patients with white coat and sustained hypertension. So this is why we should pay attention to these women also and continuously monitor them.
Yes.
Now, my next question is for Dr. Sadhana Mehta, ma'am. What is masked hypertension? Dr. Mehta, are you there? So So Dr. Rekha, can you take up this question?
Yes, sure, ma'am. Mask hypertension is just reversal of the white coat hypertension. In this, when we take the patient's blood pressure in our OPD or healthcare workers, when it measures, then the blood pressure will be normal. But in ambulatory and home BP monitoring, the readings will be more. And this is mainly seen related to the job anxiety or a smoker or some psychological disorders. Stress, work stress is more in such patients. And this is more severe because patients are mostly land up in the cardiovascular disorders and they need proper treatment like the essential hypertension.
And how do you diagnose it? That you
By
have
the
already...
ambulatory BP monitoring, and if it is more elevated, then we mark it as the masked hypertension.
We have two different conditions, white coat hypertension and masked hypertension. Both are different, but both of them can lead to increased cardiovascular risk, and it can lead to increased incidence of preeclampsia in our women. So we need to pay attention to this. Now, coming back to our patient, she was put on low-dose aspirin. She came back to us at 31 weeks. Her blood pressure now in clinic was 145/93. Since she had a gestosis score of 3, is there any test which you can offer her to screen for preeclampsia? This is for Dr. Hansali Nima.
Yes, because she has a gestosis score 3 at the start of pregnancy, and now she is turning up at 31 week. We need to understand what is her clinical and hematological condition. We'll do basic blood test along with liver kidney function test and assess the blood flow to the baby through Doppler indices, and we'll try to find out how we'll try to reassess with gestosis scoring the projection, how she is going to behave in further ahead in the pregnancy. We'll try to get the baby matured with steroids or consider magnesium sulfate. And as far as further detailed scoring is considered, there are futuristic tests coming up, which is a ratio of SFLT by PLGF. It is basically soluble FMS like tyrosine kinase 1 by placental growth factor ratio. The SFLT is an anti-angiogenesis factor, and placental growth factor is an angiogenesis factor. So the ratio gives an idea of the level of imbalance at the level of trophoblast, which is later on reflected in terms of generalized endothelial injury in the body, maybe at the level of liver, kidney, or to the fetus. The most notable feature of this ratio is that because the chemical damage starts first and later on is reflected in the body, so the test, being a screening test, gives an idea of upcoming damage by around 5 to 6 weeks. That is the important thing. So we can predict whether or not the maternal perinatal complications are going to appear with this particular patient, and we can buy some time to continue the pregnancy, especially in preterm preeclampsia.
Yes, so Hansali, you have so nicely presented all details about SFILT and PIGF ratio. NICE has recommended this ratio to rule out preeclampsia in women between 20 and 34 weeks of gestation. So there are two categories, early onset preeclampsia and late onset preeclampsia. It is said that the negative predictive value of this ratio to rule out preeclampsia within 1 week, the cutoff was less than 38. So if it is less than 38, then the chances of developing preeclampsia are almost nil, 99% less. Our patient had SFILT PIGF ratio of 33. So her risk of developing preeclampsia in next 1 week was nil. There was no risk. But it even says that there are chances of 94.3% of developing this in next 4 weeks. So can you elaborate on these findings? And so this mentions that LD has worked for this patient and other advantages of this SFILT ratio.
Yes, as it gives an idea of the potential complications appearing in the woman. So if it is negative, we know that this patient is low risk. We can plan daycare or OPD care support to the patient, or rather plan inpatient care. And also it gives an idea of chronic hypertension, and it is observed that it is also associated with unexplained stillbirths because it is associated with placental functioning. So this ratio does has a high association with abnormal perinatal outcomes. As far as these screening tests are concerned, the basic we have to keep our clinical judgment on the priority and take help, use this test as the accessory help, because in practical what is more accessible, more available, we depend on that. But yes, there is a future of this test, like we have troponin for MI, something this test promise for future.
Yes, very rightly said, Hansali. We have these clinical predictors like Gestosis score, but then biochemical predictors are coming up, and in which this SFILT-PIGF ratio has a promising results. For multiple pregnancy, the cutoff is 53. Now, details about outcome of this patient. Our patient progressed to 38 weeks. She had an uneventful progress and vaginal delivery of a baby weight 2.9 kg. Low dose aspirin was continued at till 36 weeks. She was asked to come for regular follow-ups to monitor this white coat hypertension and was advised to achieve pre-pregnancy weight by 12 months and to limit inter-pregnancy weight gain through a healthy lifestyle. So everything turned out to be well. Now I invite Dr. Brajbala for the next case.
Anu, next, please.
Yes.
So after initial discussion about the white coat and mass hypertension, we are coming to next clinical case scenario. She is a 31-year-old second gravida belonging to low socio-economic status, and at 6 weeks pregnancy, she is coming to us. She had a history of eclampsia and fetal growth retardation in her previous pregnancy, for which her delivery was done at 32 weeks, 8 years back. Her BP at booking is 110/75, and her BMI is 30.6. So next, my question is to Dr. Devendra Patil. And I think Dr. Devendra is in.
Am I audible, ma'am? Am I audible?
Yeah, you're. So why is it important to screen this patient with this history of past history of eclampsia?
Okay, thank you very much for inviting me. And as we know, she has past history of eclampsia. She is a obese patient, and she also had history of preterm delivery and also growth restriction in the baby. This all are the cocktail for the next pregnancy going to preeclampsia. So these patients have to be need to be investigated, and there is a increased risk of preeclampsia in this patient. So obviously we need an investigation.
So there is 8-fold increased risk of dying from cardiovascular disease, and 5-fold increased risk of dying from stroke. So we need to screen her. And what are the various ways in which we can predict preeclampsia?
So there are combinations
in
of tests.
First trimester.
Yeah, in first trimester there are combination of tests which we can do to identify the whether the patient can go into preeclampsia or not. So first is as we have seen the Gestosis score which we can do. And then there is we can ask a history where maternal risk factor we can look for the previous history of preeclampsia, whether she is a chronic renal disease patient or is there a history of diabetes or multiple gestation. There are multiple factors. Then we can look for the mean arterial pressure, and we can also do USG, a uterine artery Doppler, where we see the pulsatility index of the patient. And there are some biochemical markers which we can do, which is like pregnancy associated plasma protein and then placental growth factor, which we can see.
So nowadays there are multiple things available to detect the risk of preeclampsia in first trimester itself with the history, but particularly history in the first visit. Detailed history is very important. BMI is very important. What intervention was done in last pregnancy, so very important. And other than that, values and biochemical prediction values. They are very important and helping to
नहीं उसके
assess
बारे
the
में कुछ
risk
नहीं,
of
मैंने सिर्फ अपना यूट्रस
preeclampsia.
दिखाया और बताया कि ओवरीज नहीं निकल रही.
So this PEPA, low PEPA, is seen in 8 to 23% of women with preeclampsia. It provides some predictive value when combined with uterine artery PI, but not as good as combination of uterine artery and PP13. So cutoff mom is 0.4 or less, and PEPA level less than 0.5 mom, a higher risk for preterm delivery, FGR, stillbirth, and preeclampsia. So low PEPA, not only preeclampsia, but fetal outcome is also indicative by low PEPA. Simultaneously, placental growth factor can be done. So it also gives us indication about the early onset preeclampsia in 55% and late onset preeclampsia in 33%. So can someone tell about the uterine artery pulsatility index? It's a diagnostic value and its sensitivity and predictive values.
The uterine artery Dopplers are done in the same sitting when we are doing the nuchal translucency scan. And if that time the PI, if they say is more than 95th centiles, then this patient needs to be kept on a low dose aspirin. So combination of uterine artery Doppler and a low PEPA is a very good, has a very good predictive value to tell us that she is at risk of developing a preeclampsia or fetal growth restriction. So previously they used to give a lot of importance to the notching, the resisting index, but nowadays I think all the fetal medicine specialists are using only the uterine artery Doppler, it's PI. And the PI more than 95th centile, they say is the single marker which is very sensitive.
So what are the screening methods sensitivity? Dr. Sadhna Mehta madam, is she available? I think she is again not available. So madam, you can continue, Neena.
So first thing is the clinical history, the maternal factors, which will give us the gestosis score. That we can give, that will give an idea of say up to 76%. Then we come to the biochemical screening and the ultrasound at 11 to 13 weeks, which will give us an idea of the uterine artery Doppler and a PEPA. And when we combine all the history, the gestosis score and this, then the predictivity rate goes as high as 80%.
So by maternal factor and MAP, only 76% is detection rate. By combining, the detection rate for early onset preeclampsia is 75% and late onset is 47%. If we do mini combined screening by uterine artery PI and PLGF, that increased to 82% and 40%. So with adding everything, the sensitivity and detection rate increases. So, Dr. Mathu ma'am, are you available?
Yeah.
Hello. Yeah. So,
Hello.
what can we offer her for
Can you hear me?
prevention? At this first trimester, what we can offer her for prevention of complication and improving her fetal-maternal outcome?
Bridge, basically it was said that they should be started after 12. But now if the gestosis score is high, even we can start the low dose aspirin even before 12 weeks, because when we give the low dose aspirin, and that too, in low dose, the different studies are done. And they say from 75 and ranging up to 150, the different, some give 100, some give 75, some give 150. But 75 is good enough for low dose aspirin and has less perinatal and maternal complications and good prevention rate. So this can be given.
So very rightly said, madam, that previously we were starting from 12 weeks onwards only. But if gestosis score is high and she had already having previous history of eclampsia, we can start early, and dose can be variable from 75 to 80, 150 milligram. Although ACOG recommends 81 milligram, but we are having availability of 75 and 150. And as per his FIGO recommendation, if her weight is less than 40, then less than 100 milligram. And if weight is more than 40, then 150 milligram. And it was said by Dr. Rekha previously that it is better to give in the night time. And the mechanism of action was already explained by Dr. Rekha. So
actually, the FOXY ICOG guidelines, they have given and they have recommended 75 milligram to be given. And they say the role is that it balances the thromboxane A2 and the prostacyclin balance.
So, madam, is there in risk of abruption and PPH higher in the aspirin group?
No, on the other hand, it decreases the risk of abruption. So much so because this is acting as a preventive drug. So in that case, there is no increase in the risk of abruption and PPH.
So basically, if we start early, it decreases the risk of abruption. But if we start late by 16 weeks, then placentation is already completed.
Yeah,
so there
because
is
the
chances of
placentation is
abruption.
already taken place, then definitely that abnormality has occurred already.
And it is seen when we give advice aspirin to patient and she's taking and suddenly she has spotting and she consult with her GP on any relative and they says you're taking aspirin, it is causing spotting, so stop it. So what is the opinion of house on the spotting associated with aspirin? Should we stop or should we continue?
I think it should be continued. Any local bleeding should be seen if there is any, and it should be continued.
And if
but
you need to
definitely,
take
if there is heavy bleeding, then we should stop it.
And if the patient complains of nasal bleeding, then we sometimes need to stop it.
Yes, it happens in summer months, particularly women comes with the nasal bleeding and very rightly said.
They may have this
So
bleeding.
if we need to take emergency section, then do we need to stop or we can go ahead with this thing?
No,
Spinal
ideally we
anesthesia.
should stop. And the FOXY ICOG again says that 2 days prior to the surgery, you can stop. Ideally, there are different groups which say, some say 7 to 10 days, some say 5 days. But they say
But
2
now
days
with
prior.
now with low dose aspirin, anesthetist doesn't ask us to stop it, and we can take emergency cesarean section even with regional anesthesia. It is by the FIGO SDP screening prevention guideline.
Yeah,
So
but they say that, the closed spaces, it should be avoided if an emergency cesarean is to be taken. So in the closed space, like when you are giving the regional anesthesia, we should avoid.
So other than aspirin, any other medication which you
Can
would
I
like
just
to?
intervene here,
Yeah.
Braj?
Yeah,
Actually,
please.
yes, it is true for low molecular weight heparin that you should stop it at least 3 days prior. Previously, also, we used to have this recommendation that it should be stopped, but over the period now, with lots of experience, we have come to a conclusion that even when the patient is on aspirin and you need to go for emergency cesarean section or she delivers, then there's no bleeding problems. Whatever bleeding occurs because of aspirin is only the capillary oozing. So it doesn't make much of a difference. So even if you operate her or she goes into spontaneous labor with aspirin also, it should not be any problem. So there's no
Sneha,
recommendation that it has to be stopped.
Sneha, the question is regarding whether the regional anesthesia is to be given or general anesthesia in case of emergency cesarean section if the aspirin has not been stopped.
Oh. So yeah. So ideally, for any procedure, regional anesthesia has to be preferred. the reasons all of you know that for general anesthesia, it has its own problems like excessive bleeding and all these things. But as you have rightly pointed out, for a crow's pace, definitely you have to be little watchful. That much we can say. But as far as the low dose aspirin is concerned, it is only the platelet aggregation and the capillary dilatation. Still, it doesn't have any significant effect as far as the bleeding is concerned. So I don't think there is any separate recommendation that it should be. Regional anesthesia, that too preferably epidural, is the preferred anesthesia. Yes, all of us in majority, we are doing it under spinal anesthesia. Though in cases of eclampsia and other complications, we prefer regional the general anesthesia, because we get a good control of all the procedure. The anesthetists are happy because they get a good control with general anesthesia. I think that's all.
How does calcium helps? Anyone, Dr. Sadhna Mehta, Dr. Neena Madam, anyone can take up this question.
The actual mechanism of action, how it helps, is still under study, but different opinions are available. When the calcium levels are low, the parathormone level increases, and that can lead to vasoconstriction, and even the renin-angiotensin, the aldosterone mechanism all get disturbed. So keeping calcium levels high, giving them more than 1000 milligram calcium a day has it has been noted that it gives good results and a better control of blood pressure.
So it is 1.5 to 2 milligram of calcium daily requirement. Sufficient amount is required for to prevent the incidence of preeclampsia as well as preterm birth. So one more case scenario, 37-year-old Primey reports in early pregnancy. She is known diabetic and conceived after IVF-ET. What are her chances of developing hypertensive disorders of pregnancy? What medication would you start for her? And would the gestational score apply for her? Dr. Devendra, Neena ma'am, anyone can take up this.
We're looking to the history. She has a very high chance of developing a blood pressure. Her age, diabetes, and IVF pregnancy, all bringing her in the high risk group. And she is definitely a candidate who will be starting a low dose aspirin daily. Her gestational score is very high.
So if we calculate by gestational score, the initial 1 to 14 are number 1, then next onward 2, and next onward 3. So if she is elderly primary, more than 35, she is primary 1, 1, that conceived after ICSI 1, 1, 1, 3, and history of diabetes, and so 3 plus 3, it's 6. So she is very, very high risk for getting this gestational hypertensive disorder.
So Braj, now there is one more case. So should we start with this, or?
You can start. I will call Dr. Vidya if she's coming. Then we will interrupt in between.
So now moving on to the third case scenario. Mrs. P, 24 years old. Primary gravida, booked. Case belonging to a low socioeconomic status, no known medical illness, no significant family history, has had an uneventful antenatal course till now. She presents at 31 weeks of gestation with a blood pressure 160, 110, and 2+ proteinuria on dipstick. She has no complaints. She had come for a checkup. Now my question is for Dr. Rekha. Can you think of gestational hypertension in this case? And
ma'am, not only gestational hypertension, but also we have to think in this case the preeclampsia, because her BP readings are very high, and apart from this, she is having proteinuria +2. So definitely we'll go for the all detailed investigations. Apart from the normal ANC investigation, what we do, we'll do the renal function test, liver function test. Then we can go for the markers also, as earlier discussed. that soluble factor, tyrosine kinase 1, and placental growth factor ratio. Then apart from this, we'll do the uterine artery color Doppler, and her mean arterial pressure also will calculate. So we have to definitely think in terms of the preeclampsia, this patient, and we'll start the treatment.
Few words about gestational hypertension. It is seen after 20 weeks. When it is
Yeah.
not associated with proteinuria, we call it gestational hypertension.
Gestation.
There is no target damage. If it occurs less than 34 weeks, may progress to preeclampsia. So actually, this case was a case of preeclampsia. We admitted her and started her on oral labetalol, and all routine investigations were done. Mention one clinical parameter which guides you in the choice for antihypertensive. So it is 160, 110, and we need to give her antihypertensives.
Yeah.
So how would you decide which is the best? Which one would you give for this patient?
Ma'am, labetalol is the drug of choice, and pulse rate will calculate that if it is more than 100 per minute, so labetalol is the drug of choice. And if it is less than 100 per minute, then we'll give the calcium channel blocker. Then we'll advise the nifedipine.
Yes. So usually we start labetalol, which is safe. Nifedipine is not given routinely, but nowadays because of it, it also causes tachycardia. Now her lab investigations have come up, all those which Dr. Rekha had ordered. Hemogram, hemoglobin 10, platelet count 1.4 lakhs, urine examination, albumin 2+, liver enzymes were normal, uric acid, creatinine are normal, coagulation profile. If plate was not done because it is done if platelets were less than 1 lakh, serum electrolytes, peripheral blood smear for hemolysis, and fundoscopy. These are the investigations which had been advised and are normal. On ultrasound, a single live fetus in cephalic presentation, biometry corresponds to 28 weeks. She was 31 weeks by pregnancy, so 3 weeks growth lag. AFI 8 centimeters, estimated baby weight 1.1 kg. Umbilical artery shows absent end diastolic flow. In MCA, there is brain sparing effect and cerebroplacental ratio is of 1. So now it is for Dr. Hansali. Can you please summarize this case?
Yes, ma'am. She is a primey who has developed a preeclampsia at 31 weeks. She is clinically stable in terms of hematological parameters, but has got fetal compromise as indicated by Doppler. So at this time, our plan would be to at least provide maturity to the baby with watchful surveillance of maternal parameters.
So we will keep her hospitalized, but we want to know how long before decision. So is there any method by which you can predict her prognosis?
Yes,
She
apart from
cannot afford SFILT and PLGF ratio.
Yeah, as I mentioned, we will keep a watchful vigilance on the clinical symptomatology, new onset of symptoms. But along with that, there is a module, a calculator developed, which is called PIRES. That is a preeclampsia integrated estimation of risk. So this calculator demands the input of certain maternal parameters, symptomatology, plus hematological status of the mother, and then it gives an idea of which risk group the woman is, and it gives a projection of how much time it will take for her to land up in the complications. So we can plan our treatment and hospitalization accordingly.
So yes, this is also something new and something which we do not practice, the full PIES calculator. It has been very nicely explained by Hansali, but its benefits are, it would help us manage early onset preeclampsia better, help in smaller centers to identify women who are likely to become severely ill within next 48 hours, and who need to be transferred. So who need specialist care, and so that there is delay in preventing delay in transporting these serious women to facilities where they can receive appropriate care. Now, the various parameters which it utilizes are gestational age at diagnosis, symptoms of chest pain and or dyspnea, oxygen saturation by pulse oximetry, platelet count, serum creatinine, and aspartate transaminases. The reason why 48 hours was chosen was to allow for clinical decisions such as administration of steroids, max self, stabilization of hypertension, and transfer to a higher center. A threshold of greater than 30% risk is suggested as a threshold to rule in the outcome. So this is the whole calculator. It is online. We put in these parameters and it tells us the risk. Like in this patient, 30% probability of adverse medical outcomes were 30%. Now, demerits of this module is that there is no quantification of symptoms and FGR is not included. So for high-income countries, another mini PS calculator was started. Now, this included gestational age, previous deliveries more than 20 weeks, chest pain or dyspnea, headache or visual changes, vaginal bleeding with abdominal pain, her systolic blood pressure, dipstick proteinuria, and SpO2. And according to this, a probability risk was calculated and it was quantified. So if it was with between 0.6 to 0.7, it was poor and so immediately referred. This was done in some countries. Its performance has not been validated outside the context of a prospective trial. But one thing important is it can be done in the periphery also, and they can decide when to shift and whom to shift immediately. Now, since the risk score is moderate risk, how will you manage this patient and what are your goals? This question, anybody can take up. This question was for Dr. Devendra Patil or Dr. Sadhana Mehta. Anyone? Sadhana ma'am, have you joined? No. Dr. Patil? The Hansali. I think I can see Hansali. So Hansali, please take this question.
Yes, as mentioned, we need to buy time to get the baby matured. So as we have given her magnesium sulfate, we have given her steroid, and if needed, we'll transfer her to tertiary center. And once the and we'll try to prolong the pregnancy till the patient is stable, and accordingly plan delivery at around, if we can stretch up to 37 weeks, that is the ideal in such women.
No, but if once there is a urine albumin of 2+, I don't think we can stretch it too much.
Ma'am, she has got absent flow, so we'll be doing Doppler assessment twice weekly, and we'll see when further deterioration happens. We'll plan at least by 34 weeks.
So this is all individualized decision which has to be taken. Suppose she's an IVF pregnancy. We won't wait. That is what. It is always an individualized decision. Because she's 31 weeks, baby under control, fetal Doppler showing absent and diastolic flow, we can wait for a few days only, maybe 2-3 days.
Yes.
She has to be kept admitted, but under close surveillance. Now, in expected management, what we are doing, we should counsel her again. And the decision to continue such management would be made on daily basis. And median time of prolongation is only 7 days. Maybe after 2 days, we may take a decision. Daily, we have to counsel her. The reason why we want to have some time is to improve the prognosis of the baby. A day or more in utero reduces an ICU stay by 3 days. The goal of expectant management is to achieve fetal maturation in utero when gestational age is less than 32 weeks, because it is 31. Had it been 32 weeks, we would be able to take a decision of delivering her earlier. Now, again, this question for Dr. Sadhana Mehta, I don't think she's there.
Maxilf is definitely indicated. It will work as a neuroprotection for the fetus, and plus it will prevent eclampsia. Steroid prophylaxis is definitely to be given. And in expectant management, we need to check her liver functions, renal function, and especially we have to be vigilant about the HELP syndrome. Coagulation profile has to be done if the platelet count fall below 1 lakh. And in the coagulation profile, most important is the PT, IPTT, and the INR.
Yes.
Sometimes we do fibrinogen levels and D-dimer.
In the presence of FGR, Doppler also has a significant role. So absent end diastolic flow every 2 days we need to repeat. And if there is a reverse diastolic flow, then we take our initial decision.
As far as steroid prophylaxis is concerned, nowadays it is said that even at 38 weeks, if we are doing a elective cesarean section, it should be given.
Yes, that is sure. Before 39 weeks,
Otherwise, till 35,
if a
mainly we were
cesarean
giving.
section is taken, then like if a planned cesarean is taken, then it is essential to give steroids, a single dose steroid before the cesarean section.
Yeah.
Now, Poonam, Didi, now in this case, when will you interrupt expectant management?
See, when we see that either the baby is getting worsened or maybe the maternal condition is becoming poor. So in either case,
If she
if her
starts
condition
complaining
is
of headache,
deteriorating,
epigastric pain,
the urine albumin is increasing, or there are chances of HELLP syndrome. So all these cases when any or maybe breathlessness is there or epigastric pain is there and all those things. So all the markers or the general condition or the fetal condition is deteriorating. In that case, definitely we have to interrupt the expectant management and terminate the pregnancy.
Now coming back to our patient, she remained admitted, and as advised by you, Maxulf and steroids were given. Her investigations were repeated after 48 hours. They remained within normal limits. Her BP hovered between 135/85 to 140/90. The fetus was monitored by Doppler twice a week. It continued as absent and diastolic flow, and the CPR coming 0.9 at cerebroplacental ratio was 0.95. At 32 weeks, her BP shot up again, 170/115, and she complained of severe headache. So what will you do now?
As we see that the BP is shooting up so much, 171 and 115. So we will give, for preventing eclampsia, we will give the Maxulf, the loading dose, and also IV levotiol to reduce the blood pressure. And then we will plan whatever the method be, depending upon the obstetric indication, plan her termination of pregnancy, maybe deliver her whatever we want in whatever way.
Now we know that nifedipine and Maxulf both can cause headache due to vasodilatation. How do you differentiate headache due to the headache from that associated with eminent eclampsia?
if such a patient complains of headache, it is always better to think of imminent eclampsia only. Very difficult to differentiate, but always consider that it is imminent.
Yes, we always, because we are more worried, we always think it as eminent, but preeclampsia headache would be progressive, bilateral, frontal or occipital, pulsating or thrombic, associated with visual changes and worse with higher BP as BP rises further, aggravated by physical activity and unresponsive to analgesics. This is the main thing. You stop nifedipine or you give analgesics and it is cured, it means it is not due to preeclampsia. Now, which mode of delivery would you prefer in this case?
C-section. A C-section.
Yes, because of fetal indications, FGR, absent end diastolic flow, and cerebroplacental ratio less than 1. This patient was sectioned at 32 weeks. Baby's weight was 1.2 kg, 5-minute APGAR score of 9. Baby was kept in NICU for 2 weeks. Mother and baby both were discharged in good health. Now, this question is for Dr. Hansali. What problems can you anticipate during an LSCS at 32 weeks?
This is a preterm seizure, so we anticipate a poorly formed seizure, lower segment, and preterm babies are often associated with malpresentation. So if it is a preterm breech, then we have to anticipate a difficult head extraction, often associated with oligo. So it adds up to the poor, taking out of the baby. And then obviously because of the preeclampsia, there are associated PPH risk. So we have to keep that thing in also mind.
So rightly said, lower segment not formed, liquor is less, and at times we can injure the fetus if we cut too deep. Trying to deliver the fetus through a thick lower segment can also bruise the baby. There are more chances of PPH, so we have to give tranexamic acid before the incision. And they have mentioned one method to deliver a preterm fetus is to deliver NCOL, just like we do in cases of HIV. There also they mentioned that deliver NCOL like this with the membranes. Now, next questions are for Dr. Devendra Patil. Why will you avoid GA in preeclampsia? And when do you
As
prefer?
we have actually we have already discussed about this. The regional anesthesia we prefer in this patient because there is overall edema of the body. There is a difficulty in intubation, and we know we have given Maxel to the patient, which causes the relaxation of the uterus, which can cause adding to the PPH. And there is also a thing that patient is unprepared. She may have a full stomach, which can lead to a Mendelssohn syndrome, which we know. And these are the points actually which favors the regional anesthesia over the general anesthesia.
But general anesthesia may be required if plates
Yeah,
are.
yeah, it is. Yeah, platelet. If the platelet count is less than 50,000, even in our setup, we prefer giving it below 80,000. And if this patient has pulmonary edema, in those cases, we do prefer giving general anesthesia.
Now, briefly tell us how you will manage her in the first 24 hours after delivery, and will you give NSAIDs for pain relief?
Okay, basically we are being a tertiary care unit, so I prefer keeping this patient under observation in ICU setup. So we will continue the Maxel for 24 hours, whichever method we choose, whether it is span or the pre-charge regime. And in this case, I would prefer giving the Zuspan regime rather than a pre-charge regime because we give intramuscular injection in pre-charge regimes. And monitoring her vitals like TPR, BP monitoring, abdominal gut monitoring. One thing which I prefer doing in high-risk cases is that putting in an intraperitoneal drain, so that we can, whether if the patient is having derangement in the INR or something, we can monitor the blood loss, oozing of the blood. Accordingly, we can replenish the blood loss. And again, we look for the urine output. If it is with more than 30 ml per hour, accordingly, we do fluid management. It should be around 80 to 100 ml per hour. And these are the things which we basically see. And I prefer doing monitoring on early basis for at least 24 hours.
And which agent do you prefer for pain relief?
For pain relief, I prefer tramadol over the. Regarding this, I had a discussion with the nephrologist in our center, and just because this increase in blood pressure affect the end organs like kidney, and it can also damage the liver, the functionality of the liver and the kidney is affected. So that these NSAIDs are excreted through these two methods. So we usually avoid giving these things, and we prefer tramadol over the NSAIDs.
So even paracetamol
yes,
is
in
good.
Yeah, even paracetamol.
Paracetamol or tramadol, but NSAIDs should be totally avoided. This also we were told in a critical care conference in which the same thing that it is passed through the kidney, so it is better to avoid giving NSAIDs. How will you follow up this patient after discharge?
So continue antihypertensive for at least 3 months and watch for the normalization of the BP and screening in the pre-existing hypertension, underlying renal diseases, hemophilia, and contraceptive advice to the patient should be given, and some lifestyle dietary changes in this patient.
Yes. So learning points from this case are a full PAIRS module can be used to prognosticate the outcome when a woman comes with preeclampsia. A decision to deliver or transfer can be taken looking at the score. Once proteinuria has been noted, there is no need to test for it again. Coagulation profile is ordered only when platelets are less than 1 lakh. Fluid management in labor needs a lot of caution to prevent pulmonary edema. Difficulties during CS in preterm patient outlined with some solutions. Management of postpartum period is also been discussed. Long-term follow-up by lifestyle modifications is essential. So thank you, Dr. Devendra. And Braj, do you want to take this?
Thank you,
forward,
ma'am.
please? Braj Bala?
Hello.
Ah.
So Dr. Vidya is not joining, so we are taking the last question, but we are having just 5 minutes only left. So I will be going through quickly last case.
Okay.
If everyone says yes. So just move the slide, Anupma. So she's Mrs. B, 25-year-old P1L1, was brought to hospital with a history of having 2 convulsions in the last 6 years with sudden loss of vision. She had delivered 48 hours earlier in district hospital. On further questioning, she had only 2 antenatal visits. First one was at 7.5 months when she was found to have high BP. Investigations were done which were apparently within normal limits. She was prescribed tablet Lobet 100 milligram BD, which she took irregularly. Her next visit was at 9 months when her BP was 160 by 105 millimeter of mercury. Can you move slide, Anu? Next slide. So no notes were sent about drugs given before delivery. When the BP was not getting control, the patient was induced and she delivered 2.2 kg baby after 8 hours of induction, no history of PPH. She had 2 convulsions 24 hours after her delivery. She was given the loading dose of magnesium sulfate and was on maintenance leave. When she was coming to hospital, she was conscious at admission. BP was 130/90. She did not have any further convulsions after investigation, after admission. Anyone can sum up this? Poona madam can sum up. Anyone can
She is a postpartum case of eclampsia, and because she is complaining of loss of vision, that means she is having PRES, posterior reversible encephalopathy. That is because mainly there is a vasospasm of the occipital part, which leads to loss of vision. These patients, they respond very well to Maxel, and the vision, there is full recovery of the vision also. It takes
But
about
they are actually, because they are postpartum eclampsia, they really go worse. So we have to be very careful management. Otherwise, they may affect the vital organs like kidney, liver, and brain. So postpartum eclampsia and atypical eclampsia, these two are very notorious things.
So postpartum eclampsia is around 40% common, and it occurs after 48 hours and within 4 weeks of delivery. And we have to manage in them critical care unit with tertiary care center with all the daily laboratory test, imagings, and vital, everything need to be continue with make self infusion. And we have to be careful watching for further convulsions. So anyone can differentiate between the eclampsia and other causes of convulsions? And can we give magnesium sulfate even if we are not sure?
Yes, yes. Any women in the reproductive age of postpartum, we have to consider it as eclampsia unless proved otherwise. 99% of the cases, they are eclampsia only.
Because many times they hide the history of convulsions or any epilepsy because of the pressure from the in-laws. So we have to consider this eclampsia, pregnancy induced, and to continue with Maxel.
So now if a patient goes on convulsing, even in spite of giving magnesium sulfate, we give them leveracetam. In spite of that,
Yes.
also sometimes they continue convulsing. So those are at very high risk cases who require then advanced.
Then they require imaging.
Yes.
MRI and
imaging.
So these are her investigation: hemoglobin 11.1 gram, TLC 12,360, platelets 1.7, RBS 84, creatinine little higher 1.04, urea, LT, ST are normal, LDA 450, urine albumin 2 plus, electrolytes more or less normal, and APTT 27.7, INR 0.89, fibrinogen 343 milligram. Next, Anupma.
These are the causes of common causes.
So these are the different causes of neurological condition specific to pregnancy, or maybe pre-existing seizure disorder, or there may be new onset seizure non-related to pregnancy, not where having previous history. So eclampsia, PRACE, CVT, reversible cerebrovascular syndrome, TTP, amniotic fluid embolism, air embolism, hemorrhage, infarction, all these are specific to pregnancy. We have to keep in mind, but unless it is proved, we have to consider as preeclampsia, pregnancy-induced eclampsia. So what are the visual symptoms associated with severe preeclampsia? Anyone can take up this.
Right from blurring of vision to blindness or photophobia.
And these are mostly temporary. And they goes away after some time itself. But we need to monitor the patient in high dependency unit, or sometimes better to keep in ICU. And what are the features you have to shift her to ICU?
If her convulsions don't get controlled with our Maxwell therapy, or if there is breathing difficulty, we are suspecting pulmonary edema, or if her renal status is worsening, then we need to shift her to ICU.
So renal failure and all that we have to consider. So I'm getting call for
closing
time. Yeah. So
many points here.
Imaging we have already discussed. Just little bit about the PRACE syndrome. Anyone can take up. So anyone can describe. Hansali, you can describe.
Yes, PRACE is basically posterior reversible encephalopathy syndrome. It is because of the edema of the parietal and occipital lobe. The causes can be many, which affect the blood flow, cerebral blood flow. It could be hypertension, it could be some infection, autoimmune disease, or even drug induced. In our pregnant patient, we find it often in post as a differential diagnosis of, or a spectrum of postpartum eclampsia, but luckily the treatment is mainly supportive or the removal of the trigger, and most of the patient they recover with the time and with proper supportive care in ICU.
So basically it is due to increased BP, there is increased disruption of end capillary pressure, increased hydrostatic pressure, and there is cerebral edema leading to PRACE syndrome. And you had already described that can be seen in TTP, HSP, organ transplantation, HMOL, SLE, and all these infections, drug withdrawal, renal failure, etc. Any specific treatment for PRACE or any long-term residual features of PRACE? Dr. Neena Madam or Dr. Devendra, anyone can take.
So most of the cases, they recover by its own in a week or something. And in some cases, we see a persistent white matter patch on MRI or CT scan. Impaired cognitive function may be seen in some patients, but most of the patient recover on its own.
So we have to keep the BP controlled. That is very important. So lesson learned from this particular case is that post-delivery severe preeclampsia patient need to be monitored in high dependency unit, as postpartum eclampsia can occur in up to 40% cases, regardless of the causes of convulsions. Treat as eclampsia with Maxwell. Visual symptoms usually regress completely, and with neurological symptoms, think of PRACE always. Treatment of PRACE is Maxwell, antihypertensive, and delivery. PRACE can occur in severe preeclampsia without convulsions too. MRI should be done for diagnosis, and patient should be referred to a neurologist for long-term management. So I think we have covered from white coat hypertension, mask hypertension to Praise syndrome, everything we have covered with our expert panelists from very eminent institutes. And we have taken the panelists from medical college and tertiary care centers. Like we have to refer patients sometimes to multidisciplinary places. And I would like to thank my co-moderator, Dr. Anupma, and all the panelists, and to AMOGS for giving this platform to us for this webinar for Indore Obs-Gynae Society.
Thank you so much.
Thank you
Thank
so
you.
much.
All the
you so much,
panelists
ma'am.
for their lively
Thank
interaction.
you. Thank you, everyone.
Thank you so much for the excellent moderators, especially Dave ma'am and Tiwari ma'am. You were so energetic from 4 p.m. to even till the last. And very important and very good topic it was. It would have been
Dr.
better.
Rekha and Dr. Devendra, we actually wanted to talk to you regarding Dr. Bakshi, Foxy Vice President's suggestion was that we have to talk to all the tertiary care providers whenever our colleagues are sending their patients and you are seeing their documents, just please communicate with them, because many times patients are referred to and they are not getting any feedback. So it gives very relief if they get the feedback. So it's my
Sure.
Yeah,
request
definitely, ma'am. Definitely.
as behalf of
Sure, ma'am.
IOGS president. So it's the team of IOGS and we have to help each other.
Even from
Yeah.
my side, anyone can message me, or if they are sending their patient, and I'll definitely reply back. There is no problem.
Same thing, ma'am.
And
Same.
if I get,
And sometimes we
we are
let
we are
patient
we are always here
go
to help each
anywhere.
other.
So
See, we are here to help each other because we know complication can occur anytime in any patient, whether it is a completely normal patient or the if the patient is complicated, then it's completely okay. We know the patient is bad only, but still we are here to help. No problem.
thank you so much.
Thank you, ma'am.
Thank you
So
so much.
hearty congratulations, the moderator, Dr. Anupama Dave and Dr. Brijwala, and very good inputs from all the panelists. I would say Dr. Neena, Dr. Rekha, Dr. Hansali, Dr. Poonam Mathu, Dr. Sadhana, and Dr. Devendra. So very happy to know that you all are managing the cases at Tertiary Care Center. I think I was maybe for a few moments I was not there. I just had one question that suppose you have given a full dose of Maxab to a patient of eclampsia. You have given the full loading dose of magnesium sulfate, the 4 gram diluted intravenously and 5 gram deep intramuscularly, and you are monitoring the patient, and within say 10 minutes again she convulses. What will you do? Whether you will repeat the dose of magnesium sulfate or
No,
how?
it will be better to add
Madam Moderator, Anupama Dave, I would
Yes, we
like
would
to have your opinion as
go
expert.
2 grams further, because sometimes body
Yeah,
weight
no, I just thought I will take your opinion as an expert. So I will ask the panelists first.
Personally, if she doesn't respond to Maxel, then we give
Whether you will call this as that she doesn't respond. Within 10 minutes, she's convulsing again. So whether you label it as that she's not responding.
Maxelf also takes
In
some
other
time
words, I
to
would
act.
say how much time does it take? Whether Dr. Devendra, I would like to have your opinion.
So exact time I cannot tell you, but yes, we can repeat 2 grams of Maxelf again, and you can add Levopril also. There is no problem in adding.
So actually, the time taken for the complete action is around 20 minutes. So the recommendation is that if the patient convulses within first 15 minutes, then you may not repeat the dose of magnesium sulfate. You will just wait for the result. And if she convulses, but if she convulses after those 15 minutes, then definitely you have to repeat 2 grams of intravenous magnesium sulfate. So if at all you face such a situation that immediately after giving the Maxel, if she is convulsing, should not be in a hurry to repeat the dose, because all of you know that magnesium sulfate has got a narrow margin of safety. So unless you have that provision of monitoring all the plasma levels and clinically you are monitoring the patient, with all the three parameters, the reflexes and respiratory rate and urinary output. But immediately when you have given the dosage, you have not yet monitored and you're not aware about the kidney function also. Suppose as an emergency, the patient comes to you. So you should wait for another 20 minutes for the response. That is what. And suppose in spite of this magnesium sulfate, she convulses after 20 minutes and you have given a dose of magnesium sulfate, 2 grams. Still she convulses once again. So what is your
We
interpretation?
can add levetiracetam. We can give her another anticonvulsant.
Yes, but any other thing will click it to your mind that whether she's going into
Mannitol.
status eclampticus.
That is
Mannitol we can add.
to give them sodium pentothal.
Yeah, the treatment part will come to it later, but anything you should strike to your mind that whether she's landing up into status eclampticus. So any intracranial problem associated, either as Dr. Devendra said, in cerebral edema or intracranial hemorrhage as well. So if your patient is not responding to the full dose of magnesium sulfate and she's convulsing again and again in spite of the additional dose, think of some neurological problem, that is intracranial hemorrhage, and look specifically for the neurological deficit.
We can
Only
examine
that is what the message is.
fundoscopy can be done immediately.
That we should have done as a routine protocol for hypertensive disorders. But there are flaws for this fundoscopy as well. You may not get all the findings suggestive of retinopathy. I think Dr. Anupama can throw some light on this.
Yes, nowadays we don't do that frequently fundoscopy. Now we go for imaging directly if she has.
Exactly. That is what I'm saying, that there are some flaws that's the reason we are not doing it as a routine. So fundoscopy may not give you adequate information. So having focal neurological deficit and repeated convulsions can indicate, of course, the consciousness which she should regain after each convulsion. If she is having altered sensorium, that is also one more indication that she is having intracranial hemorrhage.
Thank you, Dr. Sneha, for your inputs. You are always aware and you are always available during your webinar. That's very best part of yours. In spite of having so many webinars in a day, you are very active. So thank you very much.
Thank you so much, ma'am. So coming to conclusion, I would like to invite Dr. Sadhna Mehta, ma'am, for vote of thanks.
I think we can see, madam. Yes.
Dr. Sunita Chauhan, ma'am. I'm so sorry. Dr. Sunita Chauhan, ma'am.
Yeah, I
For
thank
vote of
you,
thanks. I'm so sorry,
all
ma'am.
the members of IOGS Medical Disorder Committee for conducting such a informative webinar. And I also thank the convener of our Dr. Kavita Bapat and Dr. Archana Base for their words of wisdom. I thank you, the speaker for gestational diabetes mellitus, Dr. Sneha Buyar, and their chairpersons, Dr. Sumitra Yadav madam and Dr. Anupama Dave madam. I thank you to all the panelists of hypertensive disorder of pregnancy and their moderator, Dr. Prajwala Tiwari madam and Dr. Anupama Dave madam. Thank you, Dhara Singh, for conducting such a informative webinar. Thank you all for attending, and thank you, Sneha Buyar madam. Thank you very much.
In fact, I should thank all of you for having me here and such wonderful panel and expert panelists, I would say. Thank you so much for the wonderful discussion. And definitely, it will be great having more interactions with you. Thank you so much, Indore Obstetric Society.
Thank you, madam. Thank you, madam, and best of luck, madam.
Thank you so much,
Best of
ma'am.
luck, Sneha, madam, for your future.
And all the best wishes, Dr. Sneha.
Thank you so much.
All the
Thank
best,
you.
ma'am.
I need all your wholehearted support.
Sure, ma'am.
Thank you so much. Thank you.
Thank
Bye-bye.
Thank you. Thank you all. Thank you, IOGS committee.
One picture.
And thank you all the listeners.
Jyoti,
Yes, ma'am.
one pictures.
Yes, okay.
Yeah, all of us can be seen now.
Board, human violation, dear
Thank you.
Thank you. Thank you so much.
Thank you very much. Thank you very much.
Thank you.